चालू कर दे सामने की.
So if you want to draw this at the pedicle line just about 2 millimeter underneath. Okay. This is your pedicle. This is your pedicle. Okay. Then you have the superior facet, which usually overlaps the disc. Okay. So you have the superior facet. Okay. And you have the inferior facet. So the inferior facet, it goes like this. You have the lamina here, and this is the left inferior facet. This is the superior facet. Okay, and then we have the actually, if you see the X-ray, you will come to know. Okay, this is how you should see this. Okay. So you have the annulus. So and it's all 360 degrees all around the annulus is. Okay. So if you consider two vertebrae and a disc, this makes a motion segment. Okay. Now, in a degenerative disc, like what happens as we discussed now, there's a decrease in the quality of the annulus. There's a decrease in the quality of the nucleus also. Okay. So because the amino acid linkage and the annulus has become a bit more stiff in fibrotic, it creates a multiple cracks. So ultimately that allows the spring of the water content and everything. Ultimately there is a decrease in the disc space. So this starts. So what will happen? That will give rise to so that will give rise to disc bulge. Why disc bulge? Then it decrease. So this becomes lax. Okay. So what will happen if there's a disc bulge? There's a decrease.
Canal.
Both bones will come closer. So and because they have come closer, the ligaments. Which are the ligaments? A motion segment is basically not only the bones; it is the osteoligamentous
complex
structure. Okay. So annulus becomes loose. और क्या चीज पर पीछे आएगा? The posterior elements. The posterior elements, the facets will overlap. And when the facet overlaps, what will happen? This capsule will become lax. Okay. So this is the stage of your instability. So now what will happen?
The body tries to compensate by facetal hypertrophy and ligamentous hypertrophy.
So there is so because there is a ligamentous laxity.
Yes.
Okay. There will be a small bony outgrowth which will occur, or we will try to stiffen. It tries to stiffen the ligament, but there's one change. So by throwing in some calcium deposits and uneven formations, it becomes a bit more stiff. Second, by hypertrophy. So it will increase the number of fibers and will stiffen. So this is called as a spondylophyte, which will happen at both ends. Okay. And then this stiffening of the ligament. The similar thing will also happen. There will be spondylophytes here, both, and there is a hypertrophy of the capsules. Okay, so this is a stage of unnatural stability. Okay, so now, okay, so indirectly now you can see, but then this is your hypertrophied ligament if you compare this. Okay, now come here. Okay, so in a degenerative canal, you already have a disc bulge. Okay, you already have a hypertrophied facetal hypertrophy and the facet capsule. Okay, so there is already a stenosis, what to call it, a static stenosis. 1, 2, and 3 from all sides almost, and there is also hypertrophy of the ligamental flavor. Okay, now this ligament, so now there is already not there. Okay. And now what happens, okay, when you go into a standing position, okay, you have a normal cervical lordosis, thoracic kyphosis, normal. This is your normal standing position. There. Okay, so you tend to go into lordosis. So when lordosis happens, there is decrease in interlaminar distance, and when it decreases, this hypertrophied ligament, what will happen? It buckles inside. So now this ये ऐसा है, it will become like this. So now the cord which is now is pinched from all over side. So there is a constriction of CSF, and when there is a constriction of CSF, the pain substances and other toxic material generated not been thrown out. So that will start, and for all neural structures, including the roots, will not have the nutrition. So it starts getting irritated, and when it starts getting irritated, it starts showing the signals in the form of cramps and all the muscle which is right there, and hence they will not able to walk after a certain distance. The moment they bend forward, or they stoop or squat, the commonest thing, do it. When you sit on a chair, this will open up. This will open up like this. So the ligamental phleum again back to the normal stage, and the claudication decreases. So neurogenic claudication is posture dependent. It is not a demand and supply like your vascular. Okay, so vascular means you start doing activity. So even when the patient is not walking, the best test is just make them sit on this. Okay, just ask them to keep on flapping this thing. You are activating the gastric soleus, but the moment you stop activity, the pain should subside. Whereas on neurogenic claudication is basically posture dependent. Understood?
Yes, sir. Can stop it.